For having us tonight. We're going to see ALCAPA in a 3-year-old. It's a little different in small children. They have more remnants of the myocardial infarction, but they can also grow new myocardium. So we're going to look at coronary blood flow in the ventricular septum. It's often overlooked. We're going to see how ALCAPA can mimic mitral valve prolapse, and we're going to see how Q waves may be small and resolve with growth. So we have a 3-year-old. She's referred for a 2 out of 6 systolic murmur. Her body surface area is normal, and her height and weight were proportional and normal for age. The EKG showed LVH with strain and small Q waves, almost diagnostic in not in lead 1 but in AVL. So here is our diagram, our illustration. Here's the aorta. We see the right coronary artery, very tortuous, and here is the collaterals which join to the left coronary artery. Then we get reverse flow. Look at that angle there. It's really got to wrap around it, and it inserts into the posterior pulmonary artery. Also want you to note all the discoloration here, and this is a massively enlarged heart. All of this is myocardial infarction. Could be 50%, could be 80% of the myocardium is lost is damaged in the initial infarction. So here's a picture of coronary blood flow. We see the early blood flow here in the ventricular septum. We've got our tricuspid valve, right ventricle, right atrium, and here's our interventricular septum. A little bit later, we can see more of this blood flow going through the interventricular septum. Again, the right ventricle, right atrium, tricuspid valve, and interventricular septum. But when we look at this in real time, it's a little more confusing. So here's our coronary blood flow inside of the ventricular septum. Again, you might pass this off as just some tricuspid inflow, so please be careful to do a color Doppler sweep to the tricuspid valve from long axis to show the coronary blood flow. This lesion can mimic mitral valve prolapse. You might dismiss it as just another case of mitral valve prolapse, but let's look a little closer. Here we can see that there's some damage to the endocardium. We see some thickening of the chordae tendineae, and we also see the left ventricle is quite enlarged. So pre-op EKG, there is almost diagnostic Q wave here, not in lead 1, but in lead AVL. We also see LVH with strain pattern, inverted T waves, very tall complexes, and this is really some impressive cardiomegaly. So severe cardiomegaly here. It's measuring about 4.23 in a 3-year-old. Again, we can see the damaged endocardium, and I want to point out this blood flow here. Very easy to dismiss this as an artifact, but in this case, this is probably the most important finding here. But again, the mitral insufficiency, damage to the mitral valve, and infarction of the papillary muscles and chordae tendineae are common, especially at this age. Where you can see them more clearly. As you get older, it's not quite. So here's our cardiomegaly. It was really impressive, and this was read as severe cardiomegaly, and I agree. It almost fills the chest here. This girl is all heart. So again, we can see the cardiomegaly. We can also see some damage to the myocardium here, and this is the area of the septum where we're going to see that ventricular septal blood flow. So let's look at the right coronary artery. Okay, we can see it's a little bit bigger, but you might pass that off as normal. Here's the RVOT and the left atrium. Let's have a look at the left coronary artery. Here we can see the aorta and the pulmonary artery. Here's the left main coronary artery, and again we can see this is coming into the posterior part, and look at that angle. It comes off posteriorly and it has to make almost a right angle to get to its supply of blood flow from the right coronary artery. So here we see it in real time. It's not so easy to see. We can see the right coronary artery coming off up here just for a second, and we can see the left coronary artery going into the posterior pulmonary artery. So again, CT is showing us this posterior insertion and that huge angle that we have to make. It's really quite comparable here. In fact, the echo may even show this better than the CT shows it. So very close correlation. You can even see this outcropping here. So here's a short axis, and I think we can see a little bit of thinning in the ventricular, in the posterior wall here. We can see a bright papillary muscle, and the endocardium is also bright. So let's see that on CT. Yeah, very large heart, looks much bigger on CT, and quite a bit of thinning. Let's go down. And again, we can see some more thinning, very large heart, but not as much, and the endocardium doesn't seem to be showing up as being bright here. So again, we can measure the right coronary, and I just like to show people how we can make a false coronary, very convincing. I can even see color blood flow coming through it. So please avoid these false coronaries. So at follow-up, our patient had a successful reimplantation of the left main coronary artery. We see normalization of heart size, normalization of the EKG, and yes, even the mitral valve is recovering. We see less mitral regurgitation. So 3 months post-op, we can see the Q waves are getting smaller, and there's less voltage. But 4 years post-op, it's a completely normal EKG. So just because somebody has a normal EKG doesn't mean they don't have ALCAPA. So conclusion then is to avoid false coronaries. Be sure and check the ventricular septum with color flow, and be suspicious of mitral valve prolapse. It might be more. And remember, the Q waves may resolve with growth. So just because you have a normal EKG doesn't mean you don't have ALCAPA. And also look for our upcoming report in case transthoracic echocardiography findings in late detection subaortic membrane and patent ductus arteriosus, impact of surgical intervention. Thank you very much for your attention.